Good morning. My name is Gretchen Wortman. I am Vice President for Policy and Program of the National Minority Quality Forum and Director of our Institute for Equity in Health Policy and Practice. Welcome to the launch of the Institute for Equity's Policy Webinar Series. Today's webinar is also the third in a series that explores the potential of the All of Us research program to advance efforts to diversify the clinical researcher cohort in the United States. Our topic today is a vision for the future, creating new knowledge through the All of Us Researcher Workbench to redress health disparities and inequities. I am joined again by Dr. Karriem Watson, Chief Engagement Officer of the All of Us Research Program at the National Institutes of Health, and Director of their Division of Engagement and Outreach. Dr. Watson oversees the strong network of All of Us community partners, participant ambassadors, and research organizations with a focus on engaging people and communities who have been left out of medical research in the past. Dr. Watson has earned a doctorate in health science, a Master of Science in Basic Medical Research, and an MPH in Community Health Sciences. He has served as a principal investigator on multiple projects, including those funded by the National Cancer Institute, the National Institute on Minority Health and Health Disparities, and the All of Us Research Program. Dr. Watson and I are joined today by Dr. Kiera Atkins, a visiting postdoctoral scholar at Vanderbilt University Medical Center, and Dr. Scott Emery Moore, an assistant professor in the Francis Payne Bolton School of Nursing at Case Western Reserve University. Dr. Atkins studies the genetic and environmental risk factors of women's health conditions that disproportionately affect underrepresented populations. Currently, she is using the All of Us Researcher Workbench to better characterize polycystic ovary syndrome in diverse communities that are at an increased risk of developing chronic cardiometabolic disorders related to PCOS. Lots of words there. Dr. Atkins received her doctoral degree in biomedical sciences from Meharry Medical College in 2021, and a Bachelor of Science in Biology from the University of Alabama in 2016. Dr. Moore's research examines the influences of biological and psychosocial dynamics, including sex, gender, and minority identity-based differences. He incorporates multi-level and integrative analytic approaches to improve our understanding of the impacts that systems, community, interpersonal, and individual level factors have on aging, health outcomes, and well-being among marginalized adults. Dr. Moore has research expertise in quantitative and mixed methods decision-making, as well as clinical and interventional experience working with vulnerable populations, including sexual and gender minorities. To set the stage for our panelists, I'd like to take a few minutes to provide an overview of the All of Us Research Program. The National Institutes of Health, through the All of Us Research Program, is gathering health and lifestyle data from 1 million or more US residents to inform a longitudinal cohort study that will be operational for at least 10 years. This study is critical to our national efforts to enable more precise research that can lead to more effective therapies and thus reduce patient risk. Of particular interest to the National Minority Quality Forum was the objective articulated by Dr. Francis Collins, then Director of the National Institutes of Health, that at least 70% of the participants in the All of Us Research Program will represent populations that are historically underrepresented in biomedical research. These HUBR populations include, but are not limited to, ethnic populations other than white non-Hispanic males, LGBTQ+ individuals, women of color, and individuals who reside in rural or non-metropolitan areas. The All of Us research program, therefore, represents a publicly funded pathway to creating the research opportunities and new knowledge that are essential to redressing the centuries of structural bias, regardless of the nature of the intent, that have resulted in a devaluation of the health and lives of populations that can no longer be marginalized. Given the equity plans that have been produced by 80 federal agencies in response to President Biden's executive order regarding racial equity, the National Minority Quality Forum continues to be hopeful for leadership and progress in the health services research sector. Some quick guidelines before we begin the presentations. Throughout this webinar, please feel free to enter your questions into the Q&A box, the Q&A box, not the chat box. We will not be monitoring the chat box for questions. Questions submitted in the Q&A box and those submitted during the registration process that can be answered by these panelists will be posed after all presentations are presented. We will attempt to answer as many of your questions as possible. We will hear first from Dr. Watson, followed by Dr. Atkins, and then Dr. Moore. After they have completed their presentations, we will open the discussion to questions from the audience and from the moderator. Dr. Watson, I turn the mic over to you.
Thank you so much, Gretchen. I really appreciate your introduction. I appreciate you highlighting the All of Us research program, providing our listeners with an overview of the program. As you mentioned, Gretchen, we've been very intentional, and you'll hear me use that word a lot in today's presentation and today's conversation, the importance of intentionality. As you've noted, there's been a lot of efforts, from the federal level to ensure that diversity, equity, and inclusion are paramount in inclusion in clinical trials. And we have taken that to heart here at the All of Us research program. Even when I think about the importance of equity, we recently hired our first director of equity and inclusion and accessibility, Dr. Martin Mendoza. And Dr. Mendoza brings to us over 2 decades of experience in this space, but also brings to us a level of accountability that we also have as a program. And I'm so happy to have Dr. Mendoza in this role as our first director of diversity, equity, and inclusion for the All of Us research program. And I like to highlight that because I want to encourage other listeners to make sure that you have people in place in leadership roles that can actually be key decision makers to ensure that your team is moving forward with intentionality around diversity, equity, and inclusion, specifically as we think about the clinical trial space. So when I think about the All of Us Research Hub, our topic today is a vision for the future, creating new knowledge through the All of Us Researcher Workbench to redress health disparities and inequities. I think about my own journey, Gretchen, as a researcher. I think about the fact that, as you noted in my bio, I'm trained in community health sciences. Specifically, I'm trained in community-based participatory research, CBPR. And that means that the communities have always been at the center of my work, even driving and helping develop my research questions. But when I think about CBPR, I think about the fact that communities have often been an afterthought when it comes to research. We're often doing research to communities and doing research on communities, and very seldomly doing research with and for communities. But I can say that prior to our first enrollment of the first participant in the All of Us research program, we actually had several listening sessions with community stakeholders and community leaders. And those leaders informed what they wanted to see as a vision for the All of Us research program. Excuse me, they informed what they thought, how we make sure. They also encourage us to address certain challenges. For example, right now, the All of Us research program, in order to engage, it's pretty much a digital platform. Now, we do have other ways of engaging populations outside the digital space. Primarily, our engagement is really centered around the digital engagement. Right off the bat, we have to acknowledge that that is a challenge in terms of equity and inclusion, because we know that, particularly in our country, the pandemic has definitely highlighted the digital divide that continues to exist. And although it's not that I'm wanting to highlight all the negative aspects of the program, but I want to call out those aspects of areas that we know we have to improve on. But what we did, Gretchen, to address that digital divide early on in our program is partner with community partners and community stakeholders that can provide, and even community health centers like federally qualified health centers, that can provide participants a guided experience through the program. And we tried our best to limit and minimize some of that digital divide. And the reason I bring that digital divide up is because now we've been very intentional. Because through our partnerships with organizations like Pyxis Partners and other community partners that we have a network of over 11 funded community partners that are actually funded to do the work of community engagement. That is technically unprecedented in what you would see in national programs. You see community partners that are sometimes a part of the different sites where enrollment takes place, but you very seldom see community partners that have been funded to guide engagement, to guide bidirectionality, to ensure that community participants' voices are at the table to steer the program. But we also have partnerships with Pyxis Partners that we have community partner and gateway initiatives, such as the NMQF, that allows us to have even further reach into communities, into community stakeholders. So we can be intentional about thinking about who's not at the table. One of the things that our network, we call it a community engaged ecosystem. What this community engagement ecosystem does, it allows us to think intentionally about who's not at the table, who has been historically underrepresented in biomedical research, and what community stakeholders are out there that are often in the advocacy space for those partners, like populations living with disabilities. We have at the table the American Association of Health and Disability. When I think about the fact that sexual and gender minorities have been under-included in research, that's why our partnership with Stanford University and PrideNet is so important. When I think about the lack of inclusion of African Americans in clinical trials, that's why our partnership with National Baptist Convention USA, as well as even the work that we do with historically Black colleges and universities, and even the Black Greek letter organizations are important. Because what that does is that allows us to build on trusted relationships. It allows us to leverage the trust and the service that these organizations have had in the community long before. And they'll have that relationship in the community even long after our program is gone. And that continuity is so important. Now that brings me, Gretchen, to our engagement of researchers. We've been extremely successful, and I have to acknowledge that the reason why we've been able to achieve some unprecedented numbers in terms of diversity, equity, and inclusion in the program is in large part due to the fact that of our community partners. We have over 477 participants who have signed up for the program. Of those participants, over 80% are what we call historically underrepresented biomedical research. And of that group, 50% are racial ethnic minorities. That is an amazing accomplishment, and we've done that through intentionality around community stakeholders. Now the question becomes, how do we do that in terms of our researchers? We are now at the place where we're able to launch our researcher workbench. That means that of all the data that we collected, which is data on over 300,000 participants who have completed all the initial steps to allow their data to be accessible and where we can ask research questions from that data. Researchers are able to register through the researcher workbench, get access to data at different varying levels after they've gone through a series of training. And as a result of that, they're able to ask questions from that data. And that data set is inclusive of over 300,000 participants. And like I said, that represents racial and ethnic diversity. But when I think about participants who have, researchers who have historically been underrepresented, I also have to think about the fact that when we built our database, for example, right now you have to be able to code with R or Python. And so we said we don't want that to be a barrier to researchers. So we partner with organizations that can help provide technical assistance, that can walk researchers through how to utilize and access our workbench. So researchers like Dr. Atkins and Dr. Moore are prime examples of being able to ask questions from our database because it is such a large data set, because it does integrate the electronic health records. It integrates not only the genomic information, Gretchen, but we take the genomic data that we collect through blood and saliva, but we link that with the electronic health record. We link that with survey data. We also link that with data on the social determinants of health. And that is so key to me. And I'll end with, as a health disparities researcher who's worked focused on cancer disparities, particularly in minority men, I remember being told as a young investigator that my data sets were not large enough to really get to the power that I needed. That in order to really be able to ask the questions I needed to ask, I needed a larger data set. And I was often told that African-American men don't participate in research, and people use the term that I hate. They call them hard to reach. And I said, well, I'm an African-American man and I'm not hard to reach. I think you all are just not going to the places where we are. You're just not engaging us where we are. So that's why I worked with the barbershops. That's why I worked for fraternities. That's why I worked with faith-based leaders. And in all of my research, Gretchen, I never had a difficult time reaching the quote unquote hard to reach populations because of intentionality. But we have that same challenge in front of us today, because if we're not careful and we're not intentional, we have to make sure that the same diversity, equity, inclusion we've achieved on the participant side, that we achieve that with the researchers. And I'm so happy that both Dr. Moore and Dr. Atkins' work reflects that. So thank you so much for this opportunity.
Thank you, Dr. Watson. Dr. Atkins?
Hi, everyone. And first, I'd like to say thank you for the invitation to speak today. So as mentioned in my bio, I studied the genetic and environmental risk factors of women's health conditions. And I wanted to give a little bit more background about polycystic ovary syndrome, or PCOS, which is where I'm using the researcher Workbench for my research. And so PCOS is a very common endocrine disorder in women of reproductive age. And it's actually one of the primary reasons for infertility. And what makes it so impactful, and why I started studying it as a graduate student and why I'm still studying it now, is that it actually has way more comorbidities or other chronic conditions that can occur because of the disorder. Women are actually diagnosed based on the presence of having polycystic ovaries, so having an excess number of follicles that aren't being released during ovulation, irregular menstruation cycles, and/or high levels of testosterone levels. But unfortunately, they also have a high prevalence of things like type 2 diabetes, insulin resistance, and hypertension. And so I was really interested in studying how PCOS manifests in underrepresented populations, specifically African-American women and Hispanic women. And I was able to do that using the biobank, or the electronic health record system, at Vanderbilt University Medical Center. And so one of the things that Dr. Watson talked about is that in research, having a lot of people or having a large sample size really gives us the ability to study many different characterizations or many different risk factors for these communities. However, it's very hard to find that for different disorders or in underrepresented populations. And so I was very fortunate to have access to this EHR system at Vanderbilt. However, I really wanted to understand how biomarkers or clinical measurements can help us in improving the diagnosis process for these women, because it can take at least 3 to 4, maybe longer years to get a diagnosis. And so that's why I went to All of Us in order to replicate my study in this very large database. And I was able to use the biomarker clinical measurement information that was available there, and able to utilize the various demographic information that was available. So having access to this very large data set of racial and ethnic minorities was really, really impactful for my research, and able to give me the ability to characterize them even better with the resources that were available. And so that was very, very amazing for me, because in PCOS research, a lot of sample sizes are a lot smaller. And so having access to a very large data set was really able to push my research forward, and I'm able to study the things that I am because of All of Us.
Thank you. Dr. Moore?
Thank you so much. I'm excited to be here with you, and I want to say that I think being with both Dr. Watson, Dr. Atkins, and Ms. Wortman has been a very important part of this process to develop what I'm going to say to you today. And to be honest with you, I have to say that Dr. Watson and Dr. Atkins are both saying very similar things to what I'm going to be saying, because I think it's important for us to repeat some of these things. Because if I told you as an early career researcher, I wouldn't have the ability to do a lot of the work that I'm able to do without this program, I would be telling you 100% the truth. Because many people in my career stage, early stage investigators, we don't have the ability to have sample sizes or diversity in the way that All of Us allows us to have both. And I guess I think it's important to sort of understand why this is a valuable tool for early career researchers. And I have a couple things. I think the most important thing for us to remember is that it allows us to be meaningfully and purposefully inclusive in the work that we're doing. And those two things are really important because it's not research on people and it's not research about people. And I think that's part of this. As a gay man, I am very grounded in the idea that I want people who are being participants in my work to be able to access my work, to be able to talk to me. And as I work with sexual and gender minority communities, that's an important part of this. The All of Us Researcher Workbench has the potential to improve the health of diverse individuals and communities, not only because of the increased sample sizes and because of the location-based diversity. It gives us access to individuals across the country in a variety of different locations. And with the recent release of the control data set, we've seen the ZIP3 availability, and that's going to increase our ability to understand what role place plays in people's health. Additionally, it's a variety of data that we haven't seen in any large data set in any availability as easy as and as available and as free as the All of Us research data is. And I think that is really important. They have taken several very major barriers to access for this type of data for early career scientists and made it possible. It's not going to cost you extra money. It's going to be relatively easy to access. And I think it's great that they're moving beyond R and Python. I do encourage you, if you can learn to use R, that you should. It is free. And it's also where a lot of the newest analysis approaches are being launched first. It takes a while to put them into those graphical user interfaces that SPSS and other programs do have. So just be aware of that type of opportunity there. I don't get paid by R to say that. I don't think R pays anybody to do anything, but it's a valuable resource, and it's also a great brain challenger. I'm hoping it's going to help slow my cognitive decline later in life. So we'll see. The other thing is that as a researcher that looks at sexual and gender minorities, sexual and gender diverse individuals, we often have to sort of do the SGM, which is the term that we use as a collective term, versus cis heterosexual comparisons. And we lose a lot of the nuance in intersectional identity. And the All of Us data set allows us to use a real intersectional lens with best practices and analyses. And that is a game changer. And that's an opportunity that I think young scientists, established scientists really need to wake up and see, because we have to be intentional and meaningful when we are doing this kind of work, because intersections of minority identity do matter. I think for now, that's a great place for us to start the conversation, because I think that's a good place to move on. Sorry.
No, I think that's great. I do have a couple of follow-up questions for Dr. Watson that I don't think are a surprise. I hope not, but I know you can handle it. A lot of the conversation in over the decades has focused on what you labeled appropriately as a problematic phrase, which is the hard to reach label. We are hard to reach. We don't understand. The researchers are hard to reach. They don't know. Okay, or their skill sets are not up to speed. For Dr. Watson, I think you can take a little more time, if you can, to describe exactly what the All of Us research program is doing to engage quote, hard to reach researchers. Okay.
Thank you, Ms. Wortman. That is a great question. And no, I'm not surprised. You prepare us very well to think about how do we think about those programs. And I'll tell an anecdotal story. So I was really excited about the work that the program is doing with historically Black colleges and universities, HBCUs. And some of the work that we're doing with them, and I'm actually encouraging the program to even think deeper about doing a capacity assessment and a needs assessment of our partners, because there's not a, just like precision medicine, what I love about precision medicine is that it moves us away from that one size fits all approach to healthcare. And we'll be able to, Dr. Moore said that word that I love, intersectionality, right? We'll be able to ask those questions about intersectionality, and Dr. Atkins mentioned too, but that intersectionality also exists for researchers and institutions. So one of the things that I encourage the program, and the program is doing, is thinking about what are some of the barriers that an HBCU may have in getting access and awareness to this data. Yes, the data is free, but it takes faculty time to do that work. So we partner with certain tribal institutions, minority serving institutions, Hispanic serving institutions, and other institutions that research may not be their primary focus. We have to be intentional about thinking about that faculty time. That faculty coming onto the workbench is taken away from their teaching time. So how as a program can we even support teaching buyout time for those faculty members? I knew what it was like when I was a young faculty that wanted to do mentoring, because if you're often in a non-minority serving or any institution and you're a faculty of color or faculty from any underrepresented group, you often find yourself mentoring those students you're assigned and mentoring other students just come to your door. And you know what it was like to be othered in those places. So you take those students on. But when I would take students on, that meant that something else was being pushed aside. So whatever we can do to support researchers at those institutions, those are the ways we're trying to think outside the box. And for example, on one Saturday morning, Xavier University actually hosted office hours for R and Python training. And this was such a powerful opportunity because it had faculty in this training, as well as students in this training that could learn how to use R and Python. And like Dr. Moore said, as a public health trained researcher, I was trained in other data analysis tools like SAS and SPSS. And the first thing I said to the program was that I'm NIH funded. I have done this research. I've achieved the gold standard R01 research grants, and I couldn't even be able to access our database. And so I was really encouraging and pushing them to get SAS and SPSS. And I'm still encouraging that. But I had an aha moment. And that was R and Python is the wave of the future when it really comes to this. And when researchers graduate from graduate programs, postdoctoral programs, and they have ability to code and use R and Python, that actually increases their ability to do a myriad of a variety of type of research. So I'm more of the school of Ms. Wortman of the and. I am now encouraging programs. So I'm asking institutions, what are ways that we can support you in learning, teaching your students this free training around R and Python, because it really is the wave of the future. And like Dr. Moore said, this is not me promoting one program or another. This is me promoting equity in researcher access, because when you can know what trends are in research in terms of being a researcher, this helps you to have a seat at the table. Because I can't tell you how many times as a researcher that did health disparities that I would write a grant and I would get my feedback from that study section, and I would feel that imposter syndrome would kick in again. I would feel like, yet again, I'm behind. Yet again, someone knows something that I didn't know. I used to joke and say that there must have been a training before the training that I got to that trained other people about things. Because by the time I got there, I felt that sometimes people knew things that I didn't know. So I wanted to know where this other training take place. So I'll tell you where it takes place. It takes place in your mentors. It takes place in those conversations through faculty members who have been where you're going. And it takes intentionality around that. So two things I want to highlight before in this area, Gretchen, is one, the importance of mentoring. So we've actually partnered with a couple institutions, Baylor University being one of them. We actually have been intentional about creating teams of researchers and partnering those researchers with students to mentor those students. We also have been intentional about developing a minority student research symposium, where we have developed the All of Us Research Scholars program. What the All of Us Research Scholars program does, it allows that intentional mentoring to take place. It pairs students from institutions like HBCUs, historically Black college universities, minority serving institutions with other researchers, and together they can learn how to ask questions, to develop research questions from our workbench. Those are just two ways that we have been intentional about addressing some of those historic barriers for the quote unquote hard to reach researcher populations, because I got a seat at the table because my mentor, Dr. Nguyen, invited me to the table. When he was doing grant reviews, he invited me as a mentee to those grant reviews. When he was reviewing a paper, he encouraged me, there's a way that you can write papers and review manuscripts, and you can have a mentor review. A lot of faculty don't know those things, but you have to be intentional in how you train up and engage the next generation of researchers to do this work.
Before I ask the next question, I don't know if Dr. Atkins or Dr. Moore want to add anything to Dr. Watson's comments.
I do. Number one, thank you for saying those things, because I think it's really important for us to put it out there that sponsorship and mentorship are very important vehicles for advancement of equity. And we also, every summer for the past, well, actually not during the pandemic, I should be really, for the height of the pandemic issue times, I have tried to hire minority students to be my summer research assistants and pay them a meaningful wage out of my own funds to be able to make sure that they have the opportunity to have those relationships, to take part in the opportunity to solve problems for research study, to understand the value of those relationships with colleagues, to gain skills. Right now my current summer research assistant is learning to code in R as we speak, actually, and has a mandate to code at least an hour a day, just to even do descriptive statistics for right now. I mean, it's easy to sort of, have an endpoint, have those little milestones. By the time the summer's over, not only is he going to be able to code, but he's also going to be able to say, look at this paper I wrote, because he's done all the work. And I think that's a really valuable opportunity, is to give that hands-on opportunity, but if you can, to find a way to pay people for the work that they're doing, because I think that's an important part of gaining access to these hard to reach people, because we all do need mentors still, even at this point in time in my life. I'm grateful for the mentors that I have. I will tell you that.
Yeah,
Go ahead.
I was just going to add that, as someone who recently gotten out of their graduate program, I would not be where I am without my mentors. And I'm just thinking back to when I started. Everything was so new, a little bit overwhelming. And what I really like about all of us is that there are people who are hungry. They want to do research. They want to learn more. They want to do all of these things. And it kind of removes that step. I feel like people are doing research a lot earlier and earlier and earlier. And I even have a high school student who wants to engage with all of us. And that's so exciting because of the resources available. And just having someone there to kind of help and to guide is just so incredibly important. And I'm really happy that all of us is starting to kind of create a community of the researchers, creating these, the student research day. I know they recently had a science day, and kind of engaging all of us more. One of my favorite things about all of us is actually being able to see publicly who's doing what research, and being able to connect with people that I'm like, oh, I didn't know this other person was doing this research, and being able to kind of create this network to expand the number of people working on things. And so I think that's something that's so needed and so incredibly resourceful, and helps kind of continue to bring more information, more awareness about health disparities and precision medicine.
And Ms. Wortman, if I may, just to wrap up, I have to give credit to Dr. Sonia Springfield of the NIH National Cancer Institute. Dr. Springfield leads the CRCHD, the Center to Reduce Cancer and Cancer Health Disparities. And I like to say I grew up in the NCI CRCHD because my mentor, Dr. Nguyen, was one of their first awardees through a pipeline program when he was a medical resident. So because they invested in Dr. Nguyen over 25 years ago now with a Career Development Award, that put me at the table with Dr. Nguyen to be able to be in a pipeline with NCI. And Dr. Springfield created and her colleagues created a program called a P20, which was a partnership development grant. That was one of the first times I heard about the importance of building capacity in researchers. So what those P20 grants did is something that I'm trying to mimic in the All of Us program. They partnered NCI designated cancer centers with minority serving institutions, or HBCUs, so that the resources could be shared. Because what Dr. Springfield understood is that even the institutional resources differ. And if we're to create any type of equity, you need to have those types of partnerships in order for those resources to be shared. And in that program, I was able to get a pilot grant. And then that grant turned into a larger center grant. And through that center grant, I was able to take an undergraduate student that was in my lab through an honors program, fund him, as Dr. Moore said, for research protected time. And not only did he get funding, but he actually got tuition support for his time there. So he was able to graduate from a graduate program debt-free, and also learn how to do health disparities research. And I'm proud to say that just this spring, he was accepted into a PhD program at Tulane. I would not have been able to give Alex that opportunity had it not been for Dr. Nguyen giving me an opportunity, and Dr. Springfield giving Dr. Nguyen an opportunity, and Dr. Springfield thinking outside the box and engaging students, in this program in this intentional way. So I just wanted to kind of let people know that there's some methods that work. There's some historical precedents for how this can be done the right way. We talk about historical precedents for when things have been done the wrong way, but I think we need to give some energy and attention to historical precedents when things have been done the right way.
Thank you. I think just to follow up on that, what I've heard from all of you is, yes, the need to engage the historically underrepresented researchers, and the need to engage, and by engage and include historically underrepresented research cohorts. But what I'm also hearing, and maybe I'm hearing it because I want to hear it, is the question that's triggered is, how does that engagement change the values within the business model of research in this country, that perhaps a case can be made is designed to not be inclusive? And so I'm going to open it up to Dr. Watson to answer any part of that you may like, and then Dr. Atkins and Dr. Moore.
Oh, Ms. Wortman, I think we have to acknowledge the systemic inequities that exist in the system of the grant making process, right? Whether it's federal or non-federal, when I think about even your not-for-profit organizations, I was telling a friend recently, there's a certain privilege that goes with running a not-for-profit organization. And that's why you don't often see a lot of minorities in running not-for-profit organizations, because oftentimes in those leadership roles, you're underpaid and overworked. And so oftentimes researchers that are underrepresented racial ethnic minorities, or any marginalized researcher, we don't always have the luxury of working in those spaces where we can be underpaid because of systemic inequities that exist. Even the grant process. I was talking to a student recently who had a resume, and I said, great, this is great. I said, now send me your NIH bio sketch. And this was someone in a doctoral program. They did not know what an NIH bio sketch was. I work with my high school students. When I mentor our high school students, I start talking about an NIH bio sketch. Even within our work with Pyxis Partners for our Minority Student Research Symposium, at first, we were just gonna call the students that we engaged, Dr. Atkins, we're just gonna call them, we didn't even have a name for them. And I said, nomenclature is important, especially in the pipeline. That's why we were intentional in calling those students NIH All of Us Research Scholars, because that pushes the start button on their NIH bio sketch. So by the time they get to that study section, that reviewer will see this continuity of the experience of that student. They'll see that back when they were an undergraduate or a graduate student, and for one of our MSRS students, they're actually a high school student, they'll see that prior to even getting their doctoral degree or their terminal degree, they were engaged in NIH supported type of research. That's important, because when you go to these study sections, when your grants go to these study sections, you don't get a chance to show up as an individual. You show up on paper, and how you look on paper is what you're judged upon. And they even judge your institutional capacity. And so if they're judging your institutional capacity to be able to support your research, we have to then make sure that institutions have the resources, and so I often say it's not just enough to say, what does someone need in order to have a seat at the table? I say, what are some of those systemic and historical barriers that prevent people from having a seat at the table, right? So those are the types of things I think we have to think of as an institution to think about the historical inequities in the grant making process. And now, even thinking about the NIH R01 series, I'm not proud that I'm a part of a small group of Black researchers that have gotten an NIH R01. That should not be in the single digit percentages of less than 10% of African-American researchers who have achieved the R01. That should not be the case. But hopefully with data sets like all of us, many things that have historically prevented, is particularly those of us that do health disparities research and in community engage, it takes us sometimes twice as long to do our research because we're actually engaging the community in that work. And it's a lot of regulatory things, thankfully, that are in place to do that, but it takes a lot of work, a lot of resources, and a lot of time. Learning how to use data sets like the All of Us research data set can actually speed up what you're able to do when you think about your background information and your pilot data. So those are just some of the inequities, Ms. Wortman, that we have to think about. How do we navigate those that exist in the grant making process, the grant review process, and even the institutions where we conduct our research?
Thank you. Dr. Atkins?
Yes, I wanted to touch on something that Dr. Watson was talking about, was the pipeline and how you lose a lot of underrepresented students or trainees in that pipeline, especially from grad school to maybe going into an academic career as a professor. You start to see a decline. And so just thinking about kind of what some of those barriers might be and what some of the causes are to prevent people from continuing to do research. I think that resources and discrimination and a lot of negative experiences come into play with that. And another thing is grant funding. Do you have the money to continue the research that you would like to do? And one of the things that is really highlighted in grants is preliminary data. Having some evidence that what your idea is works, or having some evidence about your hypothesis is very important. And another reason why all of this is so great and able to help early career researchers, as Dr. Moore was saying, able to provide them with a tool and a resource to do the research that they're thinking of doing, and providing some resources in order for them to continue to do their research. And so I think that's very important. And one of the things that I also think about that all of us is so great in doing with their intentionality is by engaging these different communities and being able to create such a resource that's, building on so many different types of people in so many different places. And I'm just kind of thinking back with my graduate experience again, and just some background. And with Nashville, I went to Meharry Medical College, which is a historically Black college and university. And Meharry is right down the street from Vanderbilt. And so my mentor was at Vanderbilt, which is why I was able to use their data set. And I was able to do this through the Meharry Vanderbilt Alliance. And so I was very lucky to have kind of two institutions, two resources to pull from and be able to kind of build on that. But not many students have that. Not many students have that type of training or know things like having a bio sketch, having a CV, different professional developmental resources and things that they need in order to kind of advance in their career. And so I think all of us is kind of really helping to build up that resume, if you will, to give an earlier start to kind of help build the success as early as they can in many different career stages.
Thank you. Dr. Moore?
Yeah, I mean, I don't think I can really add too much, but I guess I want to sort of drive home the point of increasing diversity is not enough. It's beyond just increasing diversity. It's about making sure that people feel welcomed, included, and like they belong there, and they have a path toward success. And I think that's what I'm really grateful to see Dr. Watson be pushing forward in the All of Us work, is that I could easily feel comfortable showing this to a student, no matter where they are in their path, high school to doctoral work, and say, this is something that is meant to be inclusive of you and your views and your work. And while it may not be a perfect match across all the things, I mean, literally this data set goes from the genome to the sociome. It goes across it all. And truly, I think it's important for us to remember that we all work at all these different levels. And, you know, I think that policy is one of those things that when you get that ZIP3 data, you can look at how some of the lower level policies may be influencing these things. And those are important opportunities to point out to these students, I think. And thank you so much for doing it. I think that is really what the NIH needs to sort of see as a model for themselves moving forward, is understanding that you have to do more than just say, please come and do work with us. It's not just a diversity supplement. It should be a practice that is real and intentional.
Well, and Dr. Moore, I think what you've opened the door to sort of for the next question is, and concern that NMQF has, and I'm going to guess that Dr. Watson has as well, is that a fair amount of the conversation regarding equity in this country, sort of addressing, identifying, addressing, redressing equity, tends to focus on equity as an option, sort of one of a number of check boxes that one must review as they sort of, as they're looking at defining the size of the pie that's going to be associated with the research, as they're working with the provider community to redress certain behaviors as health payers, insurers and payers are looking at this. During the White House webinar 2 weeks ago, I think it was, when the equity plans were shared with the public, the equity plans that had been submitted by the different federal agencies to President Biden. The term centering equity was used by, I can't remember if it was by President Biden or Ms. Rice. And it's a term that we use at the National Minority Equality Forum as well, because in our view, and what I sensed from the comments at the White House, there's recognition that absent a fixed tent pole that is equity, these as conversations about equity collide with the business model, the money, the longitudinal data that undergird our system at the moment. Absent that censoring equity, in real time, equity becomes marginalized, or at least diminished in value as a component of whatever decision-making process is being undertaken. So I guess the question through the lens of the All of Us research program is whether, to what extent the All of Us researcher workbench centers equity in its design, in its implementation. And I'll stop there because it can go. How does the All of Us research workbench do that? If it does not, because it's a tough thing to do, to change all thought processes, automatically. What do you recommend we do as we continue on what President Biden did identify as this multi-generational journey to create equity in this country?
Thank you.
Dr. Watson, I'm sorry.
Okay, thank you, Ms. Wormer. I'll start. Well, do we center equity? I would say we center equity in our program. Yes, like as I noted before, the the recent hire of Dr. Martin Mendoza as our Director of Diversity, Equity, and Inclusion, it's not just a checkbox. It is truly someone there to be accountable. And Dr. Mendoza has an impressive track record of doing this work. And I know he would not have taken on this role if he did not have the ability to truly hold us accountable for that equity rigor. We talk about rigor in research, but we don't talk about rigor enough in terms of equity. And so, yes, it's within our mission as well. Now, within the Workbench, I would say the challenges of us centering equity there was that the Workbench is built on an R Python model that has systemic challenges in general. And so I'll move beyond just the systemic challenge we have in all of us. I'll just talk about the systemic barriers in biomedical research in general, right? And so the fact that there's an awareness issue in terms of getting underrepresented groups involved in certain sciences. When I was an undergraduate student, I didn't know about public health, and my dorm was literally across the street from a school of public health. But I saw that school as something other than me. I was at the University of Michigan, and my dorm was literally, my undergraduate dorm was across the street from the graduate school, one of the best schools of public health. But I began to ask, but I didn't see it as mine for some reason. That's probably a whole nother discussion on African Americans, on non-minority serving institutions, and the imposter syndrome. But which I've been encouraged to really rethink that word, even if that's the best word to describe what we felt in those situations. But I say that we have to acknowledge systemic barriers that exist across all the sciences. When you think about the messenger matters, you think about mentoring. If you look on most campuses and look at the faculty, that faculty in those biostatistics, epidemiology, and coding and programs, computer science programs, often are not reflective of populations that are from underrepresented racial, ethnic minority groups, often not reflective of women. So we have to do better even in the representation, because oftentimes it starts with, who do I see in that space? Because when I see someone in that space, that lets me know that there may be a place for me in that space. So what we've done and tried to continue to do is identify, again, what are those systemic things that just baked into the system that we try to navigate. And like I said before, part of that was just the training, knowing that there is a small cadre of researchers that know R and Python. And some would say, well, if you all knew that there was a small cadre of researchers that only know R and Python, why start with that? Well, one of the reasons is because there's safety is all first and foremost in our program. And when you think about the safety and the nimbleness of certain programming and coding that allows you to be able to extract the data, but not compromise the safety, R and Python is right up there at the top of that. So without compromising data safety, and to allow researchers to have a certain nimbleness to be able to ask the questions that they have, R and Python was at the time appeared to be the best to do that. Okay, so now that we know that they're the best, how do we bring up communities? How do we increase researcher capacity to get that? Someone did have a question in the Q&A saying that, you know, is all of us offering training in R or Python? We're in the process of offering almost like a course catalog, if you will, first to let people know what free training courses exist. Like there's a Coursera course out there taught by Dr. Jeff Leake, a colleague that I actually did research with in the past. He's at Hopkins, who has done an amazing walkthrough of R and Python in that Coursera course that is free to students. There's also some NIH resources that offer R and Python training, but those are the intramural researchers that are specific to the NIH. So we're working with partners to see what can we do more to create these free training opportunities for R and Python so that we can address those, that access and that equity issue. And then there's also office hours within the Workbench. So if you do sign up to work in the Workbench, there's office hours that allows you to get in there and ask those questions that are a little bit more nuanced as well. So I want to acknowledge our Data Research Center that's actually housed at Vanderbilt that supports the office hours for the Workbench.
Thank you. Dr. Atkins, any comments?
Yeah, and great point. Yeah, I'm very lucky to have had a mentor and to be at an institution where all of us, like that's one of the sites for all of us. But I did want to speak to a little bit about achieving equity. And one of the things that I think is great about all of us is that in order to achieve equity, you really need intersectionality. You know, it's not just one facet of one type of research. It's not just genetics. It's not just this, it's not just that. You need all of it to really understand the problem. And all of us is providing many different types of data structures in order to get at that question. Electronic health records, survey data, et cetera. And one of the things I think it also kind of brings this to the front is that there are differences in training. What Dr. Watson was talking about, different programs, different backgrounds use different resources. R and Python, I was trained in human genetics, so I'm very lucky to have R as a skill set. But in epidemiology, I know SPSS, SAS, data, those are more of the common programs. And so there are differences at that end. And there's also going to be differences in how people use the data, what questions that they're asking. And I think it's very important when we think about equity that we are also thinking about being inclusive of different research disciplines and kind of combining all of those together, genetics plus sociology, for example, so that we can really come to a better understanding of disparities and how to better address that with the resource that all of us is creating. And really kind of creating this, I'm not really sure what the word to call it, but creating a resource that's utilizing all of the different types of resources that are being pushed out by all of us. And so I think it's a process. And I think all of us is really given a very strong foundational enterprise, a start to achieve that. And like he was saying, that there are office hours. I'm very grateful that for some of the demos that all of us is providing, that if there is, they want you to use the data. So they do provide resources and that to help you kind of get at some of those questions with different types of methods or different types of kind of different ways to think about how to use some of the data that is available. But, as all of us kind of expands, hopefully those resources tend to expand with it so that people who want to use that or may not already know how to use it are able to learn and use it responsibly and use it to answer their questions that they're asking.
Thank you. Dr. Moore?
Yeah, first of all, I think that everything that has been said is spot on. The exemplar notebooks that are available are also really great. But also, I am going to give you the best advice I ever got and that has ever served me, and that is to ask. R is not a secret. It is not magic. It is not any proprietary. I mean, literally, for the most part, a well-meaning scientist that wants to make change in healthcare is going to share their code. Now, I will share mine, and it is ugly, and you can judge me for it because I am not a great coder, and that's fine. You can judge, and you'll see all my notes in there about, ooh, that was not a good look, or whatever else. Like it literally, it could be about whatever color code I put into the visualization, a million different things. But I mean, most of us are really willing to share. And you just have to ask, because if you're not asking, we're not sending it out to like this someplace and it's just going to sit there. Actually, we will start doing that as the NIH requires coding to be a part of data sharing. But I think that's an important piece of advice that I got given very early on. It's how you end up with doctoral funding. It's how you end up with postdoctoral funding. If you're not asking, nobody's going to be hunting it down to give it to you, right? And these people do need people to give it to. And I would much rather it be a diverse cohort of people that get those things because they're asking rather than sitting and waiting for it to show up. The other thing is that I think, one of the other things that I always tell my students is every choice that we make in research, I mean, every decision that we make in research is a choice, and we have to be able to back that choice up. And I think that what all of us notebooks sort of require you to do is to justify those choices and to really be thoughtful about what it is that you are including, why you are including it, and everything else. I mean, this is truly like the pinnacle of community engaged big data. I mean, I'm sure there's some people that would probably call it large data. We don't need to worry about differences between those things. But as far as I'm concerned, it is big data because of the big potential that it has. And this massive movement has been made real. It's not just an announcement that President Obama made with Frank Collins. It is real. Like I to be honest with you, like there are plenty of times that I've written grants and been like, this is going to be great. It's going to be huge and a lot of work, but it's going to be great. Well, then they didn't get funded, but that's fine. But this has been funded and is done. So, I mean, like, this is real. It's accessible. And so it's truly community accessible too, I think, is also the important part. And as a matter of fact, I can tell you it works, because in December, I had started working on a workspace, and I got an email saying, oh, we need a little bit more information about this or that. And there are actually a couple things. It was very specific, very easy to do. It was respectful. But I just had been where I had been working on something on a Word document and hadn't transferred everything appropriately and hit submit. And then there you go. It's already done. And then somebody goes back and checks it in a reasonable amount of time. It's not like 7 months later they came back and said, wait, did you do that? I mean, it was literally like a few days at most. But it's because somebody is really looking at this stuff. Somebody really cares about the intentionality, the decisions that you're making, and making sure that what you're saying is available and accessible to the community. And that means everybody, not just participants, not just researchers, not just NIH folk, but everybody.
Excellent. So what I saw the question in the Q&A regarding whether one should learn R in Python. And it occurs to me that we're having a conversation here regarding what it takes to access the All of Us Researcher Workbench. But I'm hearing something else that I think is an additional value, that the process of learning to use the All of Us Researcher Workbench and then using it positions one to access the research pipeline, the funding pipeline, whether it's the public sector funding or the private sector funding. Am I mistaken?
No, you're not mistaken at all. And I think the thing that I would love to get across, it's definitely to support the All of Us Research Program and access to our workbench. But it's, for me, Ms. Workman, it's actually larger than that. It's about understanding equity in data and democratizing data, really. And in order to democratize data, we have a lot of work to do, but part of that is understanding analytics, right? Part of that is understanding, how do you get access to the data? As we have this, I can't even say we're moving towards, we are in the era of machine learning and artificial intelligence. And one of the things that I learned early on in that space was data out is only as good as data in. So who's putting the data into the systems and the codes that are being written to put that data into the system? It's very important that those coders understand lived experience, because if they put certain data in without understanding intersectionality, if they understand just the DNA and they don't understand the ZNA, the zip code, then that data that they put in there, or that data they may get out, it may be very nuanced. And so what I hope people walk away with is, of course, for an appreciation for the All of Us Research Workbench. But I also hope you walk away thinking about this concept of team science. You may not be a biostatistician, you may not be an epi person, you may not actually want to learn R or Python. But how do you partner with others that know that? I, as a health disparities researcher, I always had a basic scientist that I knew I could go to understand. The last grant I got was an R01 looking at lung cancer disparities in African-American men. And Dr. Moore, it went from what you said, it went from the genome to the sociome. We looked at certain protein methylation that may be happening in African-American men as a result of not just the fact that they smoke, but what happens when you smoke and you're exposed to racism? What happens when you smoke and you're exposed to elevated numbers of stress? What happens when you smoke and you live in an environment that also has elevated levels of toxins in those environments? We wanted to collect hair samples from those men to look at cortisol levels and compare that protein methylation on that cellular level to what's happening at the community level and what they feel. So we looked at both that DNA as well as their zip code. And we had a basic scientist doing that, an epidemiologist doing that work, and then I brought the community health science to that space. And that's what I hope people walk away with as well, is that in order for us to address the health disparities that we see today, it's not a one-size-fits-all approach. You're gonna have to understand intersectionality. So in addition to you understanding data, so I hate to break it to you, but you might have been trained as a basic scientist, but you don't have the luxury of only knowing basic science. You're gonna have to learn some sociology with that basic science training. The same for the sociologists, the same for us training health disparities. We don't have the luxury. I depend on my master's in basic science a lot in my work. So you don't have the luxury anymore of just sitting in your lab, whether your lab is actually at the bench or in the community, of doing this siloed, isolated approach. Our community deserves better. That woman who's dealing with reproductive health issue, who's been sent home and never received a diagnosis, she deserves you to take into your training some intersectionality. She deserves for us to have a data set where Dr. Atkins can understand what happens in PCOS and cardiovascular disease. What is that intersectionality that exists? Because she deserves to get a diagnosis that can allow her to get the treatment and the interventions that will allow her to have a healthy life. So when I think about this more than just the researcher access. I think about our participants who gave us that data. They want to know that they gave us that data and we did something with it that can really begin to address the health disparities that we see today.
Thank you. Dr. Atkins, anything to add to that?
No, I think that was very well said.
Okay.
I think that like when we're thinking about research, people tend to think, oh, basic science is one thing, clinical research is another, translational research is another, but we're all contributing to the same goal. We're just at different steps. And so, we need to start kind of combining it, coming together, putting all of that research together. It shouldn't just be one thing, because that gives you one answer. That only gives you one perspective, one lens. And research should be more than that. Like you're saying, the people who are suffering from the conditions, the diseases, the disorders that we're studying deserve better. And we can do that by really advancing the way that we're doing research, thinking about it in another way, pulling in other people with different types of experiences, different types of expertise. I've learned so much by talking to different groups of people, by listening to how someone else looks at this. And even like Dr. Moore was saying, like having someone looking at, like having an outside person kind of coming in, taking a step back and looking at something that you probably been looking at for such a long time and being like, oh, have you ever thought about this? And it seems so like just so straightforward and so simple, but can make a huge impact. So having different voices, different types of science, different types of research, different types of people coming together, I think is really going to really, really advance what we're doing. And I think all of us is really being the change that's needed in research. And I'm really excited to be a part of it. And I'm really excited to learn from it and to do better. As we know more, we do better. And so I think that's something that we have to always keep in mind, and really think that it's not just one type of research that we should be focusing on, but just so many different facets to understand the problem.
Thank you. I'm going to ask Dr. Moore also if he has any comments, but while you're doing that, I've noticed that there are lots of words in the chat column. My comment to those who submitted remarks in the chat is, if you have the time, take the moment to turn it into a question that we can respond to through the Q&A box. I can't even read the tiny print in the chat, but there's an awful lot of conversation there, and it occurs to me that it may be something that should be addressed to our panelists as a—
And I am trying to monitor it, Dr.
Okay.
Ms. Wortman, just so you know, I'm looking at the chat and trying to address that in some of our comments. And I think to date, we've highlighted a lot of the things. One of the overarching themes in the chat is the importance of using health data analytics in research to build cumulative impact analytics and methodology approaches. And so really trying to think about these things like team science, and others are talking about data science proficiency, which we've talked a lot about, and the practical use and applications, including of using R and Python. So I really appreciate all the knowledge that's in the chat as well.
Dr. Moore. Thank you.
Yeah, I think I have several sort of little tidbits here. I guess one is to know that you don't have to be the expert of all the things. My PhD is in healthcare genetics. People look at me and say, "You study what again?" Because it's not my goal in life is not to connect genes to sexuality, gender identity, or any of that. I mean, there's more to genes than just connecting a gene to a thing, right? It's so deep and so broad that we have to be very, very aware of that depth and that breadth. I don't expect to be an expert in all of that. And honestly, I didn't know about R until I started my PhD program. And I took a class that required me to learn a little bit of R. It became a little bit addictive because it was an interesting analysis approach that I then used for my very first genetic paper that I ever published. And it's something that I continue to use, and I want to sort of adulterate later on in life to do some things that are very nursey in nature, because I'm a nurse, and look at some different aspects that aren't genetic at all. But having a large data set, like the All of Us data set, is one of the things that's required to be able to use some of those genetic approaches on non-genetic data. And I think that sort of thinking about those things, I also would like to tell you should practice safe stats, right? Always have a safety net, always have somebody that you can talk to that knows what's going on beyond just sort of like, oh, look at that p-value, right? Because we've sort of gotten caught up in this p-value issue, but I mean, we all know that if you have a large enough sample size, you can get a p-value to tell you whatever you want. But it's more about what it is you're doing with the data. And I think that's super important in pursuing equity, because again, you could have the best of intentions, but the impact could be horrible. And we can't think about intention and impact as a dichotomy or a continuum, right? They're highly interrelated, whether you mean for them to be or not. And I did mean for that to be sort of a pun, I guess, but yeah, anyway. I think that that's one of them. And I also think that I think that it's really important to also be willing to have those other people that do come and say, what did you forget about? Why did you not do this? Or what, and that's the part where you sort of find that aha moment that is the trigger, right? That does get you from that genome to the sociome idea. It's not just saying, oh, well, let me look at smoking in neighborhood environment, because that's not all that there is. And the impacts do run all over the place. So, yeah.
So I think Dr. Moore and the other two panelists as well, and so that for our last big question, I think the door has been open for some conversation about accountability and evaluation, both within the All of Us researcher workbench, as well as how that pulls through to those organizations who are gateways to the All of Us researcher workbench. And as sort of Dr. Atkins has mentioned several times, essentially are part of that intersectionality of creating a business model that centers equity. So I'm going to start with Dr. Watson and speaking to how evaluation of the use, the processes, the researchers has been factored into the design of the program. And then I'll ask Dr. Atkins and Dr. Moore to speak to what we all need to consider as we're undertaking our collective and separate work to creating a structure that not only acknowledges the value of equity, but actually is accountable for changing or reinforcing whatever is required processes that are in place in their universes, so that overlap where it is all centered actually triggers equity in a multi-generational way. I won't say without having to think about it, but we're correcting an equitable system rather than trying to create a system that is equitable. Dr. Watson.
Thank you for that question, Ms. Wortman. One of the things that I did, prior to joining all of us, when you do these job talks and you're asked, what's one of the things you want to focus on? And one of the things I said I wanted to focus on, after my first year was an evaluation. I wanted to actually evaluate the effectiveness of our community engagement efforts. Who are we reaching? What are some of the best practices in how we're reaching partners? And how can we replicate and scale that? I'm also trained in implementation science. In implementation science, you look at how things have been developed in one population and are they scalable in other populations? And I often say no, because the populations you develop them in, it's such a microcosm and such a quote unquote perfect world that when you try to scale and implement those things in other settings, it doesn't take into account a lot of that intersectionality, that nuanceness without actually being modified to fit that particular population. So I bring all of that to the table. And even evaluation is so important. And even you ask, how do we hold ourselves accountable in the workbench? Those same data points that we look at to see how are we doing in terms of our participant enrollment and our participant engagement, we hold ourselves accountable with those similar data points for our research engagement. We're monitoring on a weekly basis of those. We've reached a really great point in the researcher workbench where over 2,222 researchers are registered in the workbench, which is an amazing accomplishment. Our ultimate goal is to have more than 10,000 researchers registered in the workbench. And we also have an equity benchmarks in those researchers. We want to make sure that the equity benchmarks in those research, Dr. Mendoza is coming up with benchmarks and guideposts to say, are we hitting not just targets or quote box checks, but do our researchers reflect our participants? And Dr. Mendoza is right there holding us accountable for that. And so we have a way of determining when you sign onto the workbench. And some researchers have actually given us some feedback where they didn't understand, well, Karriem, why do I have to complete demographic information when I sign onto the workbench? And, there was even, information about, your training and where you train and how you train. The reason why that information is so important, because we need to know who's at the table, who's not at the table. We need to know if we're reaching those populations who have been historically not engaged in terms of research participants. So that, and if we're not, how do we put things in place to do that? And the last thing I'll talk about is, even in order to be a registered user on the research workbench, you actually have to be affiliated with an institution and or an organization that has a data use research agreement. They call DURAs. Not everyone knows about a DURA. You may be at an institution that does not have a DURA. Well, we've tried to make it user-friendly where your institution can sign up for a DURA, but as an individual, individual researcher, you cannot sign up for a DURA. Your institution has to sign up. But we've tried to make it user-friendly, but we know that effort doesn't always work. So I want people to know that if your institution, if you're at a .edu or an organization that doesn't have a DURA, go to your research office if you have one, or whomever is in the grants and contract office, and say, I'm a student or faculty here. I want to get access to the All of Us Research Workbench, but we don't have a DURA. And our office hours can help you identify how to best get your institution a DURA so you can get access to that. And if people ask, why does that need to be in place? It's 100% because of the safety and to protect the data of the participants we have. That data use research agreement allows certain guidelines and parameters to be put in place so that there's not inappropriate use of the data in our workbench. And so what may feel like a barrier, I apologize, but it's really to protect the safety of that data. But I don't want to not acknowledge that DURA is in place and must be in place before that researcher become a registered user of the workbench.
Thank you. Dr. Atkins, sorry.
Yeah, one of the things I wanted to also share with anybody who hasn't used All of Us or thinking about using All of Us is that for accountability, there is tiered access. So there is a public browser that you can kind of look to see what data is available. They have the survey questions there. They have some demographic information there, which is really, really resourceful. But in order to use the actual researcher workbench, which is what Dr. Watson was talking about, you do have to have that DURA. You do have to be affiliated with the institution that has that documentation with all of us. And you also have to go through a research ethics training as well. And they are very thorough. And they want to make sure that you know that this information, like it's private information that participants are giving to all of us so that researchers can use to advance research. And so we want to make sure that that information is protected. And so you have to go through this training in order to understand that, what to do, what not to do. And you have to update that annually. And so that's something that's very important in order to continue to, in order for researchers who are using the data to be accountable. Another thing is that with the recent release of the control tier access, that's even more training. That's more training that you have to do in order for you to understand how to use this data in a way that protects the participants who gave their data for this. Something else that I think is also a great accountability that Dr. Watson was talking about is the information that you have to provide when signing up for the researcher workbench. And this is kind of going back to what I was talking about, this public catalog of researchers. You can go there right now, look up different types of research and see who's working on what. And I think that's something that I haven't seen before, outside of like publications where you can kind of publicly look to see who's done what, but to see what people's research, what they're working on at the moment, I think it's another thing for accountability that they have to intentionally sign up and select these things or be very transparent about what they plan to do with the data, who they plan to include in their study. I think it's very important in keeping that kind of open communication between researcher and community, which is not something that I think is talked about enough. And so I think that's one way to kind of keep that accountability going with all of us research.
Thank you. Dr. Moore?
I think that, accountability does come with the idea of transparency, and not just transparency for transparency's sake, but with things that are meaningful to those people who are doing the accountability holding, if that makes any sense. Because you can call anything transparent, right? You could say we're collecting this data. That's transparent, right? But there's also some opacity there where you don't know what the data is being used for, other than those sorts of things. And I think that that's the part that makes me the most excited about this opportunity, is that it truly is not only comprehensive, but it is so community engaged and started that way. And I think early on in our conversations about this, I said that I think that that all of us chose to ask the right questions and didn't wait for an ICD 10 or 11 to catch up with some of the things that we were concerned about in equity research. And Dr. Watson clearly pointed to the fact that it was because they engaged those communities early on that was possible. And I think that it's not that they've stopped being engaged. It's actually, I think the engagement has increased. And so the opportunities are moving to this even more real, accessible, accountable, and engaged work. And again, I love the idea that somebody can call me on not having enough information, and I love that I got to see that it worked. Not because I didn't believe that it was going to work, or that I don't have any conspiracy theories to share or anything, but I do believe that having somebody say, hey, we need a little bit more information, really also made me think a little bit about, number one, why did I not copy and paste it? Sometimes you just get ahead of yourself. The last part I think that I will say, and I don't know, Dr. Watson, I hope that this is what you guys are collecting, but I hope you're also collecting sexual and gender minority identity possibilities from researchers in that early questionnaire. I can't remember at this point in time because it's been a couple of years since I actually did the first time, but I will say that I think that the trainings that are offered are top notch. And I have seen, they are better than city training, in my opinion. Hopefully nobody gets mad at me for saying that, but they're very thoughtful. They are also very concise. and they are very, very useful. And I truly wish that those slide decks were available for us so that I could share them with some of my students, because I think even if they're not going to get registered with the controlled tier, some of the stuff in that controlled tier slide deck I think was really spot on and really talked to some very important aspects of working with minority identity populations, with easily re-identifiable but not quite so re-identifiable information, but knowing that the intention isn't always the downfall of re-identifiability. It's being mindful, and it's adhering to those requirements of the All of Us program to keep those ends less than 20 at a very general, this is an N less than 20, rather than saying anything like that. Yeah.
Okay, we are 3 minutes to close. Dr. Moore, you still have the floor if you have a final closing remark to make. Dr.
Oh no, I didn't.
Atkins?
Yeah.
Okay. Dr. Atkins? Any closing
No,
remarks?
I just want to say thank you again for the opportunity to be here today to speak about our work and about how all of us has kind of impacted our own research.
Thank you. Dr. Watson, you have the final word.
Well, thank you to the NMQF for creating this forum, and thank you for you, and you all are a part of our accountability as well. Ms. Workman, I know that I will get a question from you, and we'll get an email, to say, how are you all doing this? And that's what we need. We need community partners and stakeholders like the NMQF that can hold us accountable and ask us those tough questions, because it's through that type of challenging that really allows us to put things in place to ensure that we're always moving towards equity. So thank you for that.
Thank you. And I believe contact information has been entered or will be entered into the chat shortly for I think several portals within the All of Us research program. And I'd like to thank everyone who joined us today for what, for me, has been a very informative conversation. I hope it has been for you as well. And then I'll say thank you until we reconvene at our next policy webinar. Have a good afternoon, everyone. Thank you.